Okay, so this is my presentation. It's regarding C-peptides and are they make a difference in clinical medicine. So this is my name, and this is the university where I work at, the Liberty University College of Osteopathic Medicine. It's in the beautiful foothills of Virginia. If you ever get a chance to come to America, we are maybe 3 hours from Washington, D.C. You can come and visit us, and we will show you our great place and give you great hospitality. Maybe not as good as the one that I got in Egypt with Dr. Sheltut when she invited me last year, but maybe next year I will come back with the COVID virus going down. So disclosures, if you want to take a copy of this slides, it is okay with me. I have no financial disclosures. I am not in any speakers bureaus. I don't have any financial disclosures to make. So what are we going to do in the next 20, 25 minutes? We're going to talk about C-peptide because C-peptide really is still somewhat of a puzzle in terms of when it is useful, when it is not. Let's define what it is for those people that haven't had the ability to do that. Talk a little bit about the history of C-peptide when it was discovered and how it's used. Understand the value of C-peptide as a diagnostic tool. And then recognize the value of C-peptide not only as a diagnostic tool, but also as a tool of prognosis. Finally, we'll spend a few minutes looking at C-peptide as a therapeutic modality. This is something that's relatively new and maybe some food for thought for the discussions later. So in brief, what is C-peptide? C-peptide is a short 31 amino acid polypeptide that connects the insulin alpha chain with the beta chain. We'll talk a little bit more about that in the next slide. We all know that insulin was discovered about 1920, 1921 in the University of Toronto, Banting and Best, Collip and MacLeod. But it wasn't until 50 years later that the C-peptide level was actually discovered. And the first documented use of C-peptide wasn't until 1972. So we've had about 100 years of insulin, but only about 50 years of C-peptide. Now we all know insulin very well, but we don't really know that much about C-peptide. And although we use C-peptide a lot, it's interesting to know that C-peptide levels are never really used for diagnosis or treatment. We're all doing them, but really are they of any value? So this is C-peptide. It's a 33 amino acid protein that connects the alpha and beta chain of the insulin molecule. And this is a little bit more about the insulin processing. You have pro insulin that is made in the beta cells, and then it is processed to have one of the terminal peptides removed, and therefore you get proinsulin, and that happens in the endoplasmic reticulum. Proinsulin is then further metabolized to insulin, and that's where the C-peptide is released, and then the insulin is available to be secreted. Now, the difference between C-peptide and insulin is that insulin's half-life is very short. Once insulin gets secreted by the beta cells, it only is in circulation for maybe 5, 10 minutes, 6 minutes. Whereas C-peptide is not metabolized so quickly. So it stays on for maybe an hour or two. And as such, it is a really good marker of insulin action. Insulin levels really aren't very helpful because they're metabolized so quickly. So we use C-peptide sort of as a surrogate for endogenous insulin. So again, this sort of is the text of the message I said. C-peptide is degraded much slower, about a half hour than 5 minutes. And most insulin is metabolized through the liver through hepatic effect. That really doesn't happen in C-peptide. So C-peptide is cleared in a standard fashion, making it a much more reliable marker for endogenous insulin activity. So what is a normal level of C-peptide? Normal level of C-peptide is 0.3 to 0.6 nanomoles per liter. And if you want to use the American system or the non-international system, it's 1 to 2 nanograms per mil. Of course, there is a postprandial increase by about 3-fold. So postprandially, you get the C-peptides between 1 and 3 nanomoles per liter or between 3 and 9 nanograms per mil. How can you measure C-peptide? There's several ways to measure it. Probably the easiest is the third on the list, the random C-peptide. And again, it doesn't It's kind of got a wide variety of normal because it doesn't really matter if you're eating or not. It doesn't take into account, but it's obviously very easy. It's very quick to perform. It that correlates with diagnosis. Normal levels are, again, between 0.3, 0.2, and 1 nanomole per liter, or by 0.6 to 3 nanograms per mil. Of course, a fasting C-peptide is probably a little bit better because it's easier to get and it's a lot more specific, although it really doesn't detect those rises in C-peptide happen after glucose stimulation. If you want to check that in terms of a glucagon stimulation test, you can do a glucagon stimulated C-peptide level. And this is sort of the most research reproducible test, where you get a very sensitive, specific, reproducible level of C-peptide response to glucagon. Finally, you can get urine C-peptides. We don't really do them that much in this country. I'm not sure about other countries. They may be less expensive, but they're inaccurate in chronic kidney disease. It's affected by gender, affected by creatinine concentration. So we really don't get them much. C-peptide levels, if someone's interested in how much these cost in the United States, they cost between $50 and $100 US. So that's probably like 40 to 80 euros to get a test done. But most of the time it's covered by the insurance carrier. This is how you would do a stimulated C-peptide level. You would ensure the glucose is not too low. You get a cannula, you check a C-peptide level and glucose level at 0 minutes. Then you inject 1 milligram of glucagon over 10 seconds. And then you check C-peptide levels at 2, 4, and 6 minutes. And the whole test is done in 10 minutes. So it's really pretty easy, quick test. So again, why should we check C-peptide levels? Well, C-peptide levels are a really good marker of endogenous insulin secretion. So many times we check them to find out why a person is hypoglycemic. Or as you know, if they have an insulinoma, they will have high insulin production, you have high C-peptide. Whereas maybe they are taking insulin surreptitiously, and therefore the C-peptide levels are going to be very low. But we're not going to really focus on hypoglycemia. We're going to look at hyperglycemia and diabetes. And the usual party line, reason to do that is that C-peptides may be useful to predict what kind of diabetes you have and how you respond to certain therapies. So are C-peptide levels helpful in clinical practice? Yes. No. Maybe. So we'll look at some of the controversial data between the three. So as we know, diabetes mellitus is generally 2 types. Type 1, which presents young age, diabetic ketoacidosis, fast loss of insulin. And type 2, which is polygenetic, environmental, obesity, and usually responds to oral agents. But there are, as we all know, 2 kinds of diabetes that sort of fall in the middle. There's the latent autoimmune diabetes of adulthood, which is really type 1 that presents in older age, 30, 40 years old, and the maturity onset diabetes of youth. And how do we diagnose someone with either LADA or maturity onset diabetes of youth? Now, we can do genetic testing. We can do antibody markers, but that's not always available in some places. Is there a simpler, easier test to see if someone has LADA or MODY that we can do? So we will use the C-peptide level to determine if it's type 1 or type 2, for MODY, for LADA. And in the United States and other countries, the government insurances want proof that the insulin secretion is low. So it's a criteria for continuous subcutaneous insulin infusion, low C-peptide levels. We all know the diagnosis of diabetes, fasting glucose of greater than 7 millimoles, random greater than 11, A1C of 6.5. But the criteria for diabetes does not include C-peptide. Type 1 diabetes criteria for diagnosis, you have to have diabetes plus antibodies to insulin autoantibodies, either GAD, IA2, zinc TA. There is no mention of a C-peptide as a diagnostic criteria for either type 1 or type 2 or gestational or MODY or LADA insulin. So there's no backing of a society to decide C-peptides are helpful. However, if you have a C-peptide less than 0.2 or stimulated, less than 0.3, it is significantly associated with type 1 diabetes. So you can get a C-peptide level. And if the levels are quite low, you can be very assured the person most likely has type 1 diabetes. This was a study done a couple of years ago in Sweden, where you looked at patients with type 1 and type 2 diabetes and correlated that to either the C-peptide level, whether it was fasting, random, or glucagon stimulated. And you can see that no matter what you did, the lower C-peptide levels were significantly correlated with a different type of diabetes that was later found to be confirmed by either antibody or genetic testing. I think the interesting thing about this study was that actually the best test was the random C-peptide level. The random C-peptide level was very good in determining whether or not you had type 1 or type 2 diabetes. So if you had a low random C-peptide level, you were very likely to have type 1 diabetes. And if you had an elevated random C-peptide level in the 1 to 2 range, it was most likely consistent with type 2 diabetes. So C-peptide levels can be used to help you decide how to treat the patient in the clinic. The United States government requires a C-peptide level to qualify for a continuous subcutaneous insulin infusion. The C-peptide level has to be less than 110% of the lower limits of normal, the laboratory's method. So therefore, if your low limit is 1 milligram per nanogram per deciliter, then less than 1.1 or less than 2 would qualify you for a continuous pump to be paid for by the government. So we talked a little bit about LADA diabetes. Talk a little bit more about this. Again, LADA is the most common term describing this diabetes that's sort of latent, presents with older people. They kind of look like they're type 2, but they don't respond to insulin or to oral agents. Again, even though the levels of C-peptide are generally lower, there's no mention of C-peptide in the diagnosis. But these patients generally have low C-peptides, less than 1. MODY, the diagnosis of monogenetic diabetes, should be considered in if you have diabetes as a neonate or diabetes as a child or an adolescent, but doesn't have all the other factors, the obesity, the acanthosis nigricans. And again, even though it's not diagnostic, levels of C-peptide are usually high. And there actually is somewhat of a good reason. About 5% of children actually have MODY diagnosis. And again, it's probably very hard to get the laboratory genetic testing. But if you have a high C-peptide, you might want to consider the patient having MODY and use oral agents, because many of these kids can be spared insulin treatment. They can be treated with sulfonylureas, and they actually do quite well. So this would be the first hint that maybe the person does have MODY diagnosis, a high C-peptide level. So we talked about C-peptide levels as diagnostic. How about prognostic? You know, does a C-peptide level that's high or low tell you any prediction about how you're going to do well with diabetes? And there is some data showing that C-peptide levels are a marker of not only the duration of diabetes, but the chance of getting complication, glycemic variability, A1C levels, and hypoglycemia. So this is from DCCT data, about 2,400 patients with type 1 diabetes, all had type 1 diabetes, all had GAD antibodies, and all were on insulin. But you can see as the duration from the initial diagnosis of type 1 diabetes went on the horizontal axis, the C-peptide level went down. And there was a significant amount, almost half of the patients who had type 1 diabetes had a C-peptide level that was in the either normal range or high. And the question is, having a little bit of a high C-peptide when you're diagnosed with type 1, is that beneficial? These patients obviously had a little bit of residual beta cell function. So did that residual beta function years later translate to a better outcome? So this is the study, and I have the reference here. And it did not reproduce well, and I apologize, but I'm going to walk through this a little bit. Hopefully you can see my pointer. If you can't, I'll describe it. This is hemoglobin A1C a year later, and this is C-peptide. So this is the lower C-peptide, and this is the higher C-peptide. So as the C-peptide level was higher, the A1C a year later was significantly better. Higher A1C, higher C-peptide, lower A1C. Lower C-peptide, higher A1C, it was almost a point difference. Also, in terms of insulin dose, there was a significant difference. The lower C-peptide had an insulin dose of about 0.6 units per kilogram per day, whereas the patients with the lower C-peptide had insulin doses that were much higher. This is hypoglycemia. So you can see, the lower the C-peptide, the much more likely you were to have higher hypoglycemia. And that's probably because you have to give more insulin and there's a lot less beta cell reserve. But this last slide I want to sort of accentuate is microvascular complications. And if you look at the patients with the lowest C-peptide, they had the highest amount of complications. And the higher C-peptide had lower complications. Now, again, is this due to better glucose control, better glucose variability, or is there something about C-peptide that's beneficial? And that leads me to the last section of this short presentation, benefits of C-peptide. So we know C-peptide actually has its own receptor in muscle cells and in beta cells. And C-peptide levels can stimulate P13 kinase, diacetylglycerol, and PKC in the same way that metformin does. And this can cause increased glucose influx and better nitrous oxide expression. So can this be part of the reason that C-peptide is helpful? And alternatively, can we use this to exploit C-peptide as a therapeutic agent? So this is one study, again, a little cartoon talks about C-peptide not only includes increasing glucose uptake, but also nitric oxide. And studies were done looking at resting forearm blood flow and myocardial blood flow, either on basal levels or with C-peptide. And you can see that if the addition of C-peptide, you had significantly greater forearm blood flow and, more importantly, myocardial blood flow when you had a C-peptide infusion versus a saline infusion. Significant increase in blood flow, which might be beneficial for the use of C-peptide clinically. I think clearly it says that if you have endogenous insulin, that's the best. And whatever you can do to continue the endogenous insulin, that is helpful. Once you run out of all endogenous insulin, exogenous insulin is not as good. How about complications? This study was a small study looking at C-peptide infusion for patients who had diabetic neuropathy. And after either 6 months or 12 weeks of C-peptide infusion, there was a significant increase in nerve conduction velocity in patients with type 2 diabetes and peripheral neuropathy. Now, to date, there's not been any marketing research to give C-peptide either by itself or in combination with insulin therapy, but that might be something to think about in the future. So I'm going to end my slide with a summary that C-peptide is a 31 amino acid chain that is co-secreted with insulin. Even though C-peptide levels are used a lot, they're not diagnostic. However, low C-peptide levels are associated with inadequate insulin secretion and can help you make the diagnosis of type 1 or LADA diabetes. Higher C-peptides are associated with either MODY or type 2. Lower C-peptide levels, especially very low C-peptides, indicate this patient might need more insulin, might have more hypoglycemia, and might have more diabetic complication rates. And C-peptide levels are really helpful in terms of blood flow and inflammation, and could possibly be used in the future as a treatment of diabetes and diabetic complications. Here are the references to some of the studies that I alluded to in the talk. And I thank you very much for your attention to this talk.